Hi everybody, this is Dr. A with your Basics of Chemistry video. We are going to look at the thyroid and thyroid testing. So thyroid hormones have many biological effects. They work at the molecular level and they work on specific organ systems. They are essential for setting your basal metabolic rate, which is tied to and drives the consumption and metabolism of proteins, carbohydrate, and lipid. So this is what your body does with the proteins, carbs, and lipids that you ingest. It drives normal growth and development. It stimulates neural and skeletal development during fetal life. It increases the production of red cells, and it stimulates oxygen consumption at rest. Oxygen consumption at rest, of course, is tied to basal metabolic rate. So the more thyroid hormones you make, the faster the metabolic rate is going to be. And the less you have, the slower the metabolic rate is going to be. The thyroid is essential for brain development, and if there's not enough thyroid hormone in early life and brain development, then the child will not have a properly developed brain and will essentially be mentally retarded, if that's still politically correct. Hypothyroidism, the first condition we're going to look at. Hypothyroidism results from a deficiency of thyroid hormone production, and that causes, of course, the body metabolism to slow down. The most common cause is Hashimoto's thyroiditis. In Hashimoto's thyroiditis, the body is making antibodies to thyroglobulin and thyroperoxidase enzyme. Those are two proteins that are essential in the production of thyroid hormones. It's an autoimmune condition, and so it impairs thyroid hormone production. Therefore, that is why it is a hypothyroid state, because the thyroid is not able to produce enough of the thyroid hormones, and so the metabolism is going to slow down. The symptoms of this slowed metabolism and hypothyroidism is going to be lethargy, tired, constipation, dry, coarse skin and hair, paresthesias, which are tingling in the hands and feet, and slow, deep tendon reflexes, facial puffiness, cold intolerance, decreased sweating, impaired memory, confusion and dementia, slowed speech and motor activity, anemias, and growth retardation in children. Hyperthyroidism results when excessive amounts of thyroid hormones are circulating and produced, and it is usually due to hyperactivity of the thyroid gland. The most common cause is Graves' disease, which is another autoimmune disease, and in this one, the antibody that's produced basically mimics thyroid-stimulating hormone, TSH. And so it will bind, the antibody will bind on the receptor on the thyroid for TSH, and therefore stimulate the thyroid to release more thyroid hormone, and it's going to be overstimulated, and therefore there will be too much thyroid hormones that are being released. The signs and symptoms include nervousness, fatigue, weight loss, heat intolerance, increased sweating, tachycardia or atrial fibrillation, muscle atrophy, warm, moist skin, and in some patients, exophthalmos. That is bulging eyeballs, and it's pretty characteristic, and when you do see it, you won't mistake it for anything else. So testing for thyroid function. It can be categorized in those that can measure the concentration of products that are secreted by the thyroid gland, or it can evaluate the integrity of the hypothalamic pituitary thyroid axis, or it can assess the inherent thyroid gland function or detect antibodies to thyroid tissue. So as a reminder, the hypothalamic pituitary thyroid axis, the way it works is the hypothalamus here in the center of your brain will detect the level of thyroid hormones. If there's not enough, it will release TRH, which is thyrotropin releasing hormone, which crosses over just very slightly over to the pituitary. The pituitary, when it sees the TRH, it's going to release TSH, which is a thyroid stimulating hormone, and then the TSH, it goes in the bloodstream and goes to the thyroid, their thyroid gland in the neck, and it will bind on the TSH receptor and stimulate the production of thyroid hormone, and then the thyroid hormone levels will increase in the blood. So the tests that measure the concentration of thyroid function, thyroid hormones, basically is the total T4. T4 is thyroxine, and the free T4. So the difference between total and free is total is free and bound T4. So T4 has to be transported on protein, and because it's lipid soluble, and so you can measure both the total amount and then the part of the T4 that's not bound to protein. The part of the T4 that's not bound to protein is the one that is available for biological activity. And then the total T3 is triiodothyronine, and the free T3, same thing. Some of it is bound to protein, some of it is free. Now the difference between T4 and T3, other than the number of iodine molecules on it, because basically T4 has 4 iodine atoms and then T3 has 3, but T3 is the biologically active form of the thyroid hormone, and T4 is its precursor. So T4 has to be converted into T3 for it to have the biological activity at the molecular level. The integrity of that hypothalamic pituitary thyroid axis then can be assessed by measuring the TSH, thyroid stimulating hormone, which is probably the most commonly done, and the TRH was the thyrotropin releasing hormone. So that would TRH would assess if the hypothalamus is working and releasing it, and TSH is going to assess whether the thyroid is working and releasing TSH. So total T4, its normal range is 4.0 to 12.5 micrograms per deciliter. This is the standard initial screening test to assess thyroid function because it's widely available and easy to turn around. It is an inactive form of thyroid hormone, if you will. It's the pro-hormone. It has to be activated into T3. Increased levels of T4 could indicate hyperthyroidism and or elevated concentration of the thyroid binding proteins, or it could indicate non-thyroid illness. So sometimes your thyroid, your levels will change in other illnesses, and then when that illness goes away, it goes back to normal. Decreased levels could indicate hypothyroidism, decreased concentration of thyroid binding proteins, or non-thyroid illness, again, kind of the same as the increased levels. Free T4, the normal range is 0.8 to 1.5 nanograms per deciliter, the most accurate reflection of thyroid metabolic status. So it reflects T4 that is not protein bound. A decrease in free T4 with an elevated TSH would be diagnostic of primary hypothyroidism. So primary means that the dysfunction is at the thyroid gland itself. So if you have a lot of TSH and not a lot of free T4, or even not a lot of total T4, then what it means is the pituitary keeps signaling to the thyroid to make thyroid hormone, but the thyroid is not able to do so. And so then the dysfunction is at the thyroid, and that's why it would be primary thyroidism, hypothyroidism. A decreased free T4 and a decreased TSH of less than 0.01 milli international units per liter is consistent with what we call non-pituitary hypothyroidism, or sometimes secondary hypothyroidism. Anyway, it means that here, because there's not any TSH that's being produced, so maybe there's not the TRH signal, maybe is not happening, or maybe there's a damage to the pituitary. So there's something is going on at the pituitary level, and or at the hypothalamus level, and TSH is not produced, and therefore because TSH is not produced, then thyroid hormones are not produced, and so that's more of a secondary type, or even tertiary type of hypothyroidism. Now, which one's the most common? The primary hypothyroidism, which Hashimoto's would fall under primary hypothyroidism. That is the most common. An increased free T4 with a decreased TSH would be diagnostic of primary hyperthyroidism. So that would be like a Graves' disease, where there's so much T4 that's being produced that the hypothalamus is reading it and saying we don't need to make any more, and therefore the TSH levels will drop, and that's what you would expect. And again, the overproduction is happening at the level of the thyroid, and which is why it's considered to be primary. The total T3 and the free T3, so these again are the biologically active forms of thyroid hormone. For the total T3, the normal range is 78 to 195 nanograms per deciliter. It is primarily used as an indicator of hyperthyroidism. So seeing too much total T3, too much of the active form, then we know there's hyperthyroidism. And free T3, the normal range is 2.3 to 4.2 picograms per milliliter. That's a small measurement. And it measures the unbound form of T3, again, the one that's the most biologically active. TSH, the normal range is 0.25 to 6.7 micro international units per milliliter. It is useful in diagnosing primary hypothyroidism because you would see a high TSH and then low thyroid hormone levels, but is not as useful in diagnosing hyperthyroidism. In hyperthyroidism, you would tend to see low TSH levels with high T4 and high T3. Most patients who have secondary or tertiary hypothyroidisms can have a low TSH, sometimes a normal TSH level, but it tends to be low because the defect again is, if it's secondary, it's at the pituitary, if it's tertiary, it's at the hypothalamus. Thyroid function tests are known to be altered in depressed patients, so there are things that can affect your TSH. The TSH is probably the most ordered screening test for thyroid function. There you go. That wraps it up. Thank you so much for your attention.